Good morning everyone. Myself Dr. Dwivedi, Senior Lecturer in the Department of Oral Pathology and Microbiology, BBDCODS, BBD University. Today I am going to tell you about odontogenic keratocyst and dentigerous cyst. First, let's take up odontogenic keratocyst. The odontogenic keratocyst or OKC is a distinctive form of developmental odontogenic cyst that deserves special consideration because of its specific histopathologic features and clinical behavior. There is general agreement that the OKC arises from cell rest of the dental lamina. Their growth may be related to genetic factors inherent in the epithelium itself or enzymatic activity in the fibrous wall. Several investigators have suggested that the OKC be regarded as a benign cystic neoplasm rather than a cyst, and in the latest WHO monograph on head and neck tumors, this lesion has been given the name keratocystic odontogenic tumor (KCOT). The arguments to support this change in nomenclature largely rely on studies that have shown certain molecular genetic alterations that are also present in some neoplasm. When compared to other odontogenic cysts, the OKC shows significantly greater expression of proliferating cell nuclear antigen (PCNA) and Ki67, especially in the suprabasilar layer. Almost 30% of sporadic OKCs and over 85% of OKCs associated with the nevoid basal cell carcinoma syndrome show mutations of PTCH1, an important molecule in the hedgehog signaling pathway. Also, genetic analysis have demonstrated loss of heterozygosity for various other tumor suppressor genes in many OKCs. These lesions are significant for three reasons: greater growth potential than most other odontogenic cysts, higher recurrence rate, possible association with the nevoid basal cell carcinoma syndrome. Although there are wide variations in the reported frequency of OKCs compared with that of other types of odontogenic cysts, most studies indicate that OKCs make up 3% to 11% of all odontogenic cysts. Coming to the clinical and radiographic features, OKCs may be found in patients who range in age from infancy to old age, but about 60% of all cases are diagnosed in people between 10 and 40 years of age. There is a slight male predilection. The mandible is involved in 60% to 80% of cases, with a marked tendency to involve the posterior body and ramus. Small OKCs are usually asymptomatic and discovered only during the course of a radiographic examination. Larger OKCs may be associated with pain, swelling or drainage. Some extremely large cysts, however, may cause no symptoms. OKCs tend to grow in an anterior-posterior direction within the medullary cavity of the bone without causing obvious bone expansion. Multiple OKCs may be present, and such patients should be evaluated for other manifestations of the nevoid basal cell carcinoma or Gorlin syndrome. OKCs demonstrate a well-defined radiolucent area with smooth and often corticated margins. Large lesions, particularly in the posterior body and ramus of the mandible, may appear multilocular. An unerupted tooth is involved in the lesion in 25% to 40% of cases. Here you can see a radiograph showing a multilocular OKC. Coming to the histopathologic features, the OKC typically shows a thin friable wall which is often difficult to enucleate from the bone in one piece. The cystic lumen may contain a clear liquid that is similar to a transudate of serum, or it may be filled with a cheesy material that on microscopic examination consists of keratinaceous debris. Microscopically, the thin fibrous wall is usually devoid of significant inflammation. The epithelial lining is composed of a uniform layer of stratified squamous epithelium, usually 6 to 8 cells in thickness. The epithelium and connective tissue interface is usually flat and rete-rich formation is not seen. Detachment of portions of the cyst lining epithelium from the fibrous wall is commonly observed. The luminal surface shows flattened parakeratotic epithelial cells which exhibit a wavy or corrugated appearance. On occasion, isolated foci of orthokeratin production may be found in addition to the parakeratin. The basal epithelial layer is composed of a palisaded layer of cuboidal or columnar epithelial cells which are often hyperchromatic. Small satellite cysts, cords or islands of odontogenic epithelium may be seen within the fibrous wall. In the presence of inflammatory changes, the typical features of the OKC may be altered. The parakeratinized luminous surface may disappear and the epithelium may proliferate to form ratty ridges with the loss of the characteristic palisaded basal layer. In the past, some investigators recognized a purely orthokeratotic variant of the OKC. However, these cysts do not demonstrate a hyperchromatic and palisaded basal cell layer which is so characteristic of true OKCs. Here you can see the diagram for OKC. The epithelial lining is 6 to 8 cell layer thick. There is presence of corrugation and at the basal layer is palisaded one. Next, coming to the dentigerous cyst. The dentigerous cyst is defined as a cyst that originates by the separation of the follicle from around the crown of an unerupted tooth. This is the most common type of developmental odontogenic cyst, making up about 20% of all epithelium lined cysts of the jaws. The dentigerous cyst encloses the crown of an unerupted tooth and is attached to the tooth at the cemento-enamel junction. The pathogenesis of this cyst is uncertain, but apparently it develops by accumulation of fluid between the reduced enamel epithelium and the tooth crown. Coming to the clinical and radiographic features, although dentigerous cysts may occur in association with any unerupted tooth, most often they involve mandibular third molars, accounting for approximately 65% of all cases. Other relatively frequent sites include maxillary canines, maxillary third molars and mandibular second premolars. Dentigerous cysts rarely involve unerupted deciduous tooth. Although dentigerous cysts may be encountered in patients across a wide age range, they are discovered most frequently in patients between 10 and 30 years of age. There is slight male predilection and the prevalence is higher for whites than for blacks. Small dentigerous cysts are usually completely asymptomatic and are discovered only on a routine radiographic examination or when films are taken to determine the region for the failure of a tooth to erupt. Dentigerous cysts can grow to a considerable size and large cysts may be associated with a painless expansion of the bone in the involved area. Extensive lesions may result in facial asymmetry. Dentigerous cysts may become infected and be associated with pain and swelling. Such infections may arise in a dentigerous cyst that is associated with a partially erupted tooth or by extension from a periapical or periodontal lesion that affects an adjacent tooth. Radiographically, the dentigerous cyst typically shows a unilocular radiolucent area that is associated with the crown of an unerupted tooth. The radiolucency usually has a well-defined and often corticated border, but an infected cyst may show ill-defined borders. A large dentigerous cyst may give the impression of a multilocular process because of the persistence of bone tuberculi within the radiolucency. The cyst to crown relationship shows several radiographic variations. These are the three types of variations: central, lateral, and the last one is circumferential. Coming to the histopathologic features, the histopathologic features of dentigerous cyst vary depending upon whether the cyst is inflamed or not inflamed. In the non-inflamed dentigerous cyst, the fibrous connective tissue wall is loosely arranged and contains considerable glycosaminoglycan ground substance. Small islands or cords of inactive appearing odontogenic epithelial rests may be present in the fibrous wall. Occasionally, these rests may be numerous and at times pathologists who are not familiar with oral lesions have misinterpreted these findings as ameloblastoma. The epithelial lining consists of two to four layers of flattened non-keratinizing cells, and the epithelium and connective tissue interface is flat. In the fairly common inflamed dentigerous cyst, the fibrous wall is more collagenized with a variable infiltration of chronic inflammatory cells. The epithelial lining may show varying amounts of hyperplasia with the development of retirages and more definite squamous features. Here you can see a non-inflamed dentigerous cyst. This is the non-keratinized thin epithelial lining, probably resembling reduced enamel epithelium. This is a histopathologic diagram for an inflamed dentigerous cyst. There is present of hyperplastic retirages. That was all. Thank you.